Are we ready?
Hi there, I'm Charlie Davey. I'm an NHS clinician and I'm delighted to be working with DataCan, which is an initiative to unlock the value of data to improve cancer care. Cancer care will affect 1 in 2 people in this room. And of course, we have a rich data source through registries across the UK. But the important thing is how we use better amalgamation of data to improve the lives of people with cancer. And of course, our outcomes don't always meet up to comparison with other countries. So we are a true UK collaborative, and I'm really pleased that we're working with UCL Partners as the host organisation, working with Queen's University Belfast, working with the University of Leeds, Leeds Teaching Hospital, Genomics England, and our commercial partner, IQVIA, who have a very large resource in oncology data network with over 120 centres across Europe, and are now working with us to expand that into the United Kingdom. And if we can leverage the impact of that data so that we can reduce variation, unwarranted variation in healthcare, that will be one of the great results that we want to achieve. We've already started to increase discoverability of data by putting data onto the HDR UK gateway. And one example to mention is coming back to the children and young adults. We have showed discoverability to a paediatric renal cancer data set, and we were able to reach out at very short notice to 40 young children with a rare paediatric renal cancer, and to get an insight from them about how they wanted their data to be used. And then working with Chris Carrigan, who's our patient lead, to be able to circulate that more widely and then to take that forward. So we think that we can work in a number of different ways. One of the priority areas that we want to look at is in colorectal cancer, because we think that we can bring together routinely collected NHS data, registry data, omic data, working with Genomics England, another important partner in this collaboration, so that we can start to understand insights into disease. But then how can we then translate that into patient benefit so that we can make lives better for people with cancer?
Well done, Charlie. My name is Exlap Malloy. I lead Discover Now. Discover Now is Europe's largest longitudinal linked data set. It's up and running. It brings together data from hospitals, primary care, community, mental health, and also from outside the NHS, social care. And I thought the best way to sort of illustrate what this data is really doing and what we're doing with the hub is to give you 3 quick examples. Let's assume you suffer from a long-term condition like chronic obstructive airways disease, COPD, very prevalent. Patients are very compromised in their functionality. You might see a GP. The GP might refer you to a hospital, and the hospital might eventually refer you to community rehab. All of these are care episodes, and that's exactly how we tend to keep this data in different data sets. What we have is a holistic view of all these care interventions and touch points in the care system. And clinicians in a number of disease areas have now developed dashboards that effectively enable you to have a much more holistic care and integrated care for these patients, because they can see what happens to patients throughout the entire care ecosystem, if you like. So that's direct care. Care planning, once you have this data, you can also much more easily decide where you want care to happen. So stick with COPD, you want rehab very close to patients. So you want care centers where the prevalence is. The data that we have enables the system to make those decisions. Over the summer, we developed, for example, a flu dashboard where we can do case finding. We can find subsets of the population, citizens that have not benefited from flu jabs in anticipation of a very difficult winter. We can find those and proactively follow them up. So that's care planning. And then thirdly, research. This data and other data has been used for clinical trials for a long time, but just last week, the first randomized control trial for digital intervention for breast cancer has been run on this data with one of our cancer centers, used the consent to contact model that also sits on top of this data, and there's now increasingly a queue for this kind of application as well. The hub will enable us to upgrade the technical environment, host it in a much more modern way, get to near real time. Secondly, it will enable us to play in other data. So we have care data, that's great, and we have that in longitudinal linked ways. Bringing in patient-generated data will be of great interest. And the curation of the data has come up a number of times. Using the data will increase the quality of the data. And then finally, and my colleague Amy Darlington set this out this morning in the panel, we are now weeks away from a number of citizen assemblies to guide us in terms of governance as well as the commercial model. Thank you.
So thanks very much indeed, Axel, and thanks, Andrew, for the invitation. So my name is Aziz Shaikh. I have the privilege of being director of Breathe. I'm a clinical academic based at Edinburgh. Clinically, I work at the Royal Hospital for Sick Children, which is in the news for all the wrong reasons, academically at the University of Edinburgh. So Breathe is an initiative which is designed to really catalyse our use of the phenomenal respiratory data assets that we have in the UK. Respiratory conditions affect 1 in 5 of the population at some point in their lives. For the long-term respiratory conditions, the acute, we'll all encounter these at some point in time. What we sense is that there's an enormous opportunity to make a transformational change here. So, for example, with asthma and COPD, Axel's just been speaking about, most of the exacerbations, the hospital admissions are potentially preventable if we could really bring together the data assets that we now have, both within the health system, but also those data assets that patients are generating. So there's a lot of opportunity to predict and actually relieve some of the pressure on health systems. So these respiratory disorders are responsible for 10% of hospital bed days in the NHS at the moment. So our partnership spans academic institutions across the UK, some excellent NHS partners, third sector organisations and a number of industry partners. Patient-public involvement is actually at the heart of what we're trying to do. And really what our focus here is around trying to line up these data assets, because at the moment they are very fragmented. There's relatively few people with expertise in using these. To make these much more discoverable, again, we're doing this through the Gateway and the Alliance. What we then really need to do is curate these data assets. That's a lot of work, that's a heavy lift, but it's a price certainly worth paying, really. It's an important piece of the equation. And then we want to develop a whole range of tools to support automated analysis, visualization, work at scale. I think if we get this right, we will really drive forward substantial clinical improvements and also facilitate research efficiencies at scale. And so, for example, in the context where I'm using these data sets at the moment, my research costs in some contexts have dropped by something like 90%. What we want to do is make that far more routine than the kind of sporadic use cases that we've got at the moment.
Thank you. I'm John Bradley. I'm Director of the Gut Reaction Hub and also Chief Investigator of the NIHR Bioresource, which comprises over 150,000 individuals who have provided us with health and lifestyle information, given us consent to access their health records, and also provided a biosample from which we can extract and analyze DNA to provide genomic information. Over 30,000 of those individuals have inflammatory bowel disease, recruited from over 100 NHS trusts across the UK. Inflammatory bowel disease affects about 500,000 people in the UK, is very disabling, and the healthcare costs of in excess of £1.5 billion per year are dominated by drugs. Many immunogenetic pathways have been identified that influence the susceptibility or course of inflammatory bowel disease, and many drugs that target these pathways are in development. The aim of the NIHR Bioresource and IBD Bioresource originally was to help identify patients and individuals who could be recruited to clinical trials where there are very specific entry criteria. But as we've built it, we have created, with the help of Health Data Research UK, a very rich data asset that we are keen to share with industry. And I'm going to hand over to Mary, who's going to tell you a little bit about the models.
So the models that we've developed for the Bioresource have been done in conjunction with the Patient and Public Involvement Panel, which is quite active. We've got patients with IBD who actually, one of them was a teacher, so is very good at articulating her thoughts. So we operate either a direct fee for access model, or a number of industry partners are very keen in supporting the bioresource more generally and are providing educational grants in order to be able to access the bioresource more rapidly. One of the things that's really important, I think, going forward with the HDR UK programme is to make sure that we get a very good balance between making the data as accessible as possible and returning the investment to the NHS partners who have supported the bioresource and to the charity partners as well. So we're trying to strike a balance with that in our commercial model, but we're having a commercial partners day with the PPI team coming up soon. And I think one of the things that we're looking forward to as well for a longer term relationship is where there's been some inventive contribution for the NHS is looking at royalty shares and equity shares in any company that spins out.
So I'm Alistair Dennison. I'm the Director of Insight, the Health Data Research Hub for iHealth. And my colleague Piers Keane has spoken in more detail about some of the context of this and provided some of the case examples. So I'm going to try and be very brief to catch up some time. But just to say that within iHealth, there's two facets. One is the leading causes of blindness, things like macular degeneration. We're very proud that one of the partners of Insight is Action Against Age-Related Macular Degeneration, led by Lee, who is here today. And he's been leading the initiative around the aspects of patients and public involved in the decision-making processes through the systems that we're exploring with that group around the use of data, so that is really embedded within the functioning of the hub. And what I would say is that our North Star around the sustainability model is patient benefits. And we've explored this morning already about some of the attributes of that and about this value return to the NHS. So I think as we've explored what the data can do and the real impact that algorithms are already demonstrating in terms of retinal diagnosis, I'll stop there.
Yes, good. Right. Martin Landray from NHS Digitrials. Clinical trials are really the bedrock by which we know whether treatments work or not. They're the barrier between having a good invention and having a good therapy. And yet clinical trials have become increasingly complicated and ridiculously expensive to conduct. And that's true whether the treatment that you're investigating is a commercial product, so a pharmaceutical new drug. It is also true when we want to compare existing therapies as they're used in the health system. To give you some context, many late-phase clinical trials, so those are the trials just before you get regulatory approval, are costing $500 million, $1 billion, $2 billion per trial. Now, with a cost like that, then clearly one can't afford to develop many treatments. So many treatments or potential treatments get ditched early in the pipeline. And the second thing is that actually somebody has to pay that cost, and that's typically the health service that has to pay that in one way or another. So really our motive is to actually make clinical trials substantially easier to do by building on top of the data we've already got. And the largest data sets that we have is really focused on NHS Digital, an NHS organisation with responsibility for curating data across England, although to answer the question about is it England or UK, with a very definite vision to how does one then extend that out to the rest of the UK. And our first phase is really focusing on feasibility. So again, coming back to Carol Longson's point about a company that couldn't do a trial in the UK because the UK couldn't tell the company how many patients there were with disease X. It's a pretty obvious question, and actually how can we answer that in hours or days rather than in years? And the second question that you might want to ask is, given that there seem to be enough patients like that, where are they? And they're not all in the big academic medical centres. And so, for example, our sort of pilot study, our precursor, has already demonstrated that you can use these sorts of methods to recruit very large numbers of patients in, for example, in and around the hospitals on the retirement coast down at the south, in the North Midlands, and up into the industrial north. So in other words, one can take the trial to where the patients are, as opposed to try and expect that the patients will somehow get to where the trial might be. It's being built in collaboration with, it's being based at NHS Digital, but in collaboration with Microsoft and IBM. None of the parties have any particular rights to the data other than the rights that they already would have under normal approval processes. So all the usual governance controls remain in place to maintain the trust. And very finally, patients are at the heart of this. Patients are the motivation for this. We want to conduct trials in a way that suits patients. We want to conduct trials that produce results that suit patients, and patients are part of both the oversight group and even are part of many of our technical discussions.
Thank you. So my name's Liz Sapie, and I am the director of Pioneer, which is the acute healthcare hub. Don't you feel sorry for me having to go after this lot, after these brilliant discussions? But acute care is a new offering for academic medicine and industry and innovation, but it is a daily challenge of the NHS. Acute care is any unplanned healthcare contact. It's when somebody seeks urgent healthcare because they're suddenly unwell, or they've got new onset symptoms, or they can't cope with the symptoms of their chronic disease. And it's provided across a number of different healthcare services, not just primary and secondary care, but out-of-hours systems, the ambulance services, and hospitals as well. And this sector faces unprecedented demand and huge cost, not just to the NHS, but to patients, their carers, and their communities. But it's a sector that's had very little innovation focused upon it, because the healthcare providers are so siloed, and because most of us are blind to the journeys that patients go on as they seek healthcare in this acute, unplanned manner. And Pioneer will change this. We are already starting to curate and link data across healthcare providers, utilising the expertise of University Hospital Birmingham that's had an electronic healthcare record for over 10 years in this setting and beyond. And we're also bringing with us regional partners as well, addressing some health inequalities that are always present unless you have a true representation of health data across the nation. And we're supplementing this with data from 150 other hospitals across the nation. We're really starting to utilise this data to already have impact. We've developed some algorithms which we're testing now, which have reduced drug errors in the acute setting by 40%, which is an extraordinary achievement. And we're also beginning to identify rare side effects of drugs, because 5% of presentations involve drug reactions or adverse events associated with medications. And with our partners, and our patients are fundamental partners in this, we're now beginning to bring this data together in a meaningful way so that we can answer more imperative questions to help the NHS and help our patients and give them more choice in this setting. The kind of choices we're talking about is understanding where and when they want to access healthcare and providing them with the answers they need without necessarily relying on secondary care hospitals. And our sustainability model really focuses on our patients' benefits and their voices in making the decisions that are right for this health data use. And by taking them with us, we hope we can offer solutions that will improve healthcare for all of our patients.
Now we're going to open it up for questions to the panel, to anyone in particular or to anyone in general to take it. So we'll take the questions in groups of 3 again. So would anyone like to ask a question? 2 down here.
Thanks very much. Hilary Newis from National Voices. When I was looking at that, I was just wondering, and it's to all of you, whether any of you started to use the data sets, not just sort of clinical research, but looking at care pathways and unmet need in care, possibly even in a home setting. So it's again a valuable data resource that we've done quite a lot of work on, but be interesting to know if any of you have started to do that.
Hi, thank you. Oh, did you want to get the 3 questions first? I'm allowed to answer.
Well, there's a second question. We'll take that, yeah. No.
So it's two parts to this question. One is none of the data hubs are actually data controllers, and this issue about the sort of benefit in near real time. So it's understanding how you see that partnership with the NHS. And then if I may, a supplementary, which is more about the earlier presentation on value, which was the Moorfields model, for example, had benefit coming back to Moorfields in terms of the free access to the algorithms, and what solutions do the hubs have to thinking about how, as patients see it, the NHS is one entity, how you avoid that organisational benefit, but not necessarily for the NHS. Sorry.
Okay. Third question here, then we'll... I'd suggest Liz starts answering. You've got the microphone.
Hi, thank you. It's Rosalind Rowan again, UCL. I was very glad that Carol picked up the issue of skills and training, and I wondered, since you're all working with commercial entities, what discussions you've had about models here, because it sometimes feels as if we in the universities do all the training. We train up these wonderful data analysts, computer scientists, and then they go, and having done all that training, they then go off into industry. And I just wondered if there's any discussion about more shared models, whether it's in taking on the sorts of models that engineering has done, or other models. What you've thought about there.
Okay, we'll start.
Thank you. So if I start with the first question about processes of care, you're absolutely right that this is fundamental. And a small example I can give with Pioneer is by looking at our own data set, we've realised that people being admitted to hospital from care homes tend to land with us quite late in the day. It takes a long time for them to make a decision. And then even if they don't need to stay in hospital, they end up staying in hospital because you can't send someone home at 2 o'clock in the morning. So by understanding that problem, we've been able to put a small pilot project in place where we've now equipped some ambulance teams to go into the home via video link to talk to a consultant in ED and say, right, let's look at the patient, let's see if they can stand if they've had a fall. Actually, I don't think they need to come in. This is what you need to do. The patient stays at home rather than coming into hospital, and that consultation took 10 minutes when on average it takes about 5 hours to deliver by the time they've seen a consultant in ED, which would add on another 4 hours at best. So that is an absolute vital component, and we see Pioneer and the other hubs as having a huge role to play in that space.
Who'd like to take the second question? Okay, Axel.
Thanks for the question, and it's a sort of often overlooked aspect of bringing data together is actually the sort of who controls the data and how do you get the agreement of all the people that are the custodians of data. So in our case, and in many ways that puts also some realism to the kind of timelines, we have over 400 organizations that need to sign up to sharing the data. And we have done this not once, we have done this at least twice now, that we had to go around every single of these organizations and get them signed up to data sharing agreements. And that's really, sort of often the technical stuff gets highlighted and so on, but getting this IG environment watertight has probably taken most of the time. And there are people in the room who have done that work, and I'm sure they're willing to share their sort of scars on their backs. Having said that, it's then often tempting to say, oh, we have dealt with a kind of public trust issue. And that's why we're so keen to make this distinction that we think we have actually cracked the IG. I'm very happy to share that and the lessons, and hopefully you can accelerate this. But it doesn't replace building the public trust. And that's why we're doing both, right? Getting the IG right, but also putting an enormous amount of time and money into getting the public trust and setting the rules. To the third question, or the other question about the shared values. Well, we don't know yet, because that's precisely what we're going to discuss with the public.
Thank you. And would anyone like to talk about skills?
Can I just add that for our hub, the bioresource is where the data is held, and the data's custodian for that is the NHS Trust.
Could you lift the microphone up so everybody
Sorry.
hear? Yeah.
Sorry. So the custodian for the data is the NHS Trust, Cambridge University Hospitals. So I think that makes the public trust issue a lot more straightforward. And to your second point is getting the value back to the NHS in general. I think our data model is relating to getting the data back to the hospitals that have contributed to the data in the first place, because there's a consortium of 10 NHS hospitals in the pilot phase. And obviously, as that spreads out wider, there will be more hospitals contributing data, and they will also get some of the financial return.
Thank you.
So I think sort of joint working between some of these commercial companies and the hubs and the broader NHS is fairly critical. And one of the reasons that we were very pleased with the IQVIA relationship is that they, of course, have multiple capabilities across many areas where we can start to work with them in different fields. We've got the founder of Inspirata, a curation company, and it's having conversations with them about how we can get some of these joint working relationships established. I think also where we are very keen to advance this as well is working with some of the SMEs, where quite often they have people working within their organisations who either are still working within the NHS or have a lot of NHS expertise, that we can use some of their skills to bring that back into the NHS structures.
Can I make a comment on the training, because I've been leading a task force on this for the Academy, and I think this is a reflection of the fact that I don't think it's a bad thing that people go into industry or PhDs. The issue is really the lack of fluidity between academia, especially the NHS, and also industry. We need to create an environment where it's not seen as a bad thing or you burnt your boats, but actually you gain experience from both, or all three aspects of the ecosystem, including policy and government, and actually have something where we value people who have been in these different environments, as opposed to thinking it's either or.
So maybe I can just respond to Carol's point first. And in relation to data controllers, I mean, we're still very much in the setup phase with Breathe, but I mean, our approach is going to be to build on the work that Cell Data Bank has been doing. So I think it's similar numbers, several hundred of data controllers that they work with. What they've done is they've now got a mechanism by which that group is convened virtually. There's delegated responsibility. So it's a pretty efficient mechanism that they've been able to create. So rather than reinvent the wheel, we want to try and see if we can get that to scale up. In relation to Rosalind's point, so Aradazi and I have together lead the NHS's Digital Academy, which at the moment is focusing on developing chief clinical information officers and chief information officers. So it's very NHS facing, but in the next phase of it, what we certainly hope is that this will broaden out to industry as well, because we desperately need to increase that crosstalk.
Are there any more questions? There's one over here.
Martin Levermore, also from industry and part of Pioneer. Question to all the hubs is, how are you going to give a surety in your quality control mechanisms?
Has that stumped everybody on the panel? Go on.
Well, I think I'll take the easy bit if you like, but actually the most important bit leads off to the last set of comments, which is actually the first bit of quality control is around the governance, and it leads into governance for what? And actually, whilst everybody's talked about governance in the sense of how does data move around the environment, actually, certainly in clinical trials, and it's true elsewhere, that actually the overlap and potential for confusion, conflict, or just duplication between the right approvals and the right permissions for accessing data, for ethical research, from the MHRA around the regulatory applications, from NHS R&D, from funders. That whole environment is frankly a jungle and a mess. And researchers, and therefore patients as a consequence, can get snarled up in a horrible tangle which leads them going round in circles for months or years. Now, you talk about quality assurance, but I think that and trying to streamline some of that is a critical piece. The quality is the quality of the process as well as the quality of the data, and that depends heavily on the function, including the use you put it to. So, for example, ensuring that the results of a clinical trial done in a data smart way are understood and accepted by international regulators. There's a separate piece which is around data quality, and I think again the issue comes about data quality for what purpose, because depending on the type of analysis or the type of purpose you're using, it varies enormously. If you're worried about the care of one patient at a time, which on a Wednesday morning, normally that's what I'm worried about, then my issues around data quality are very different from if I'm doing a study of 40,000 people, 20,000, and comparing 20,000 with 20,000. I can cope with a few certain types of error in that comparison. I can't cope with errors of the same magnitude when, on a Wednesday morning when I see one patient with a possible heart attack.
Thank you. And just to add a couple of case examples around that, which actually links your question to Carol's comment around value and return of value, is I think this is a real opportunity. The quality assurance and quality measures we're putting into place, we've already discovered how this is creating learning in terms of the routinely collected data that was reflecting what's actually happening on the ground on your Wednesday morning, and which, if we can get those processes right to ensure that not only data for research, but actually data for delivering quality clinical care is right, then that's a really fantastic loop where we're delivering value back, not just to one institution, but more widely. So I'm really excited. There's a big push from HDI UK for the hubs this year to focus on our quality assurance measures and frameworks. So, and I think that one of the values of that is that benefit to the wider NHS and even beyond. I mean, I think, again, returning to the value question, I think what we're seeing is ripples of benefit. So there may be some things which are more obvious in terms of the institution where that innovation is taking place. But absolutely, I think the whole vision of the hubs is around that ripple of benefit for patients and public right across the UK.
Thank you. Are there any last questions before lunch? No? What time is people to come back? If people could come back at 1:45, but let's thank the panel now. Thank you.